Now we'll pass to the second session with the quiz. The first quiz will be with Dr. Geoffroy Vanbiervliet about the esophagus. So he is known to high skills in therapeutic endoscopy, academic professor in medicine, member of many societies, French Digestive Endoscopy Society. He is vice president of board of the French of Endoscopy Ultrasonography, member of French Digestive Society, member of European Society of Gastrointestinal Endoscopy, and is co-director of the French graduate in the US. Dr. Vanbiervliet.
Thank you, Bilal, for this kind of introduction. And dear moderators, dear colleagues, it is always a great pleasure to be here. And with the time, it became a second family, a second professional family, and a real deep and great pleasure. So this is maybe the rest moment of the session, because I will show you only very short and simple video, but sometimes it is important to come back to the basis. And I will try to obtain your opinion for the different diagnoses. I will try to show you in this video. Maybe we will have the discussion at the end of the session. One of my first master taught me in the past that the esophagus was not only a tube between the mouth and the stomach. And from this date, I try to take my time when I go inside the esophagus, because all of my young fellow push very quickly the tube inside the stomach, and they don't want to take that time in the esophagus. And when we have a look on the different diagnoses we can obtain and perform inside this segment of the digestive tract, we know that there is a lot of possibilities. So I will try to show you these different diagnoses, which could be very simple, and always one video per diagnosis, and I will take your opinion. So this is the first one. You can see that there is some mark we have performed with a knife. So there is plain lesion, flat lesion, with modification of the pit pattern of the epithelial, some modification of the color, like Pradi tried to show us during the last session. Maybe again, if you want. We put the LCI from Fuji and the BLI chromendoscopy. Of course, I don't tell you the different information regarding the patient, but there is some tobacco, there is some alcohol. It is a man. It is more simple like this. So it is, of course, a squamous cell carcinoma with this modification of the mucosal epithelial vessel. It is a flat lesion, which could be very difficult. Me, personally, I'll always retrieve the scope in BLI or in chromendoscopy when I am at the end of the gastroscopy, just to have a look on the different vascularization, because it is only sometimes a different delineation of the lesion, demarcation of the lesion, and the modification of the vessel, like this. Second one, a woman with a slight dysphagia, and this very round and small lesion, slightly depressed. in the lower part of the esophagus, tough lesion under the forceps biopsy, and small lesion. Again, of course, first, you will maybe perform a US to complete your evaluation, your analysis. It seems to be a submucosal lesion or a subepithelial lesion, because when you have the submucosal word, it means that it is in the submucosal space, but it is not only for this kind of lesion in the submucosal space. So you have to tell subepithelial lesion. And the tough aspect under the forceps, the size, the location in the lower part of the esophagus, and the low number of symptoms most of the time. It could be asymptomatic. It is most of the times in favor of a granular cell tumor. So it is very benign lesion, but you can have some huge lesion like this, and it could induce some symptoms like dysphagia. And in this case, you can discuss resections and sometimes endoscopic resection if you are a good interventional endoscopist. Third video, very simple. Haiti woman with dysphagia, with a lot of different treatment. So for you, it is maybe simple, but for the fellow, it could be interesting. Gabriel. You can see this white or yellow material, which is disseminated in all the different segments of the esophagus. It could be associated with some symptoms, and you have always to explore the buccal cavity of the patient in this situation, because it could be associated with buccal and gingival lesion also. It is associated with corticosteroid treatment, and in this case, it was associated with this type of treatment. And it is the fungal esophagitis. So if you perform some biopsy on this material, you will have the result and the diagnosis with your pathologist very easily. Another one, we put a cap because we want to perform a treatment for this disease during the same session. When you put a cap, you know that you can reduce the luminosity and it could be difficult to have a good diagnosis, but there is a lot of bubbles, there is some solid food inside the esophagus. Again, this white or yellow material, because we know that fungal esophagitis is very oftenly associated with this disease, and when you arrived, which could be difficult on the cardia, it is difficult to reach through the cardia inside the stomach. And of course, it seems to be an easy diagnostic in this case. When you go back, it is also sometimes difficult to retrieve the endoscope because it seems the patient seems to have an hypertonic cardia. You saw that. So when you got that, the diagnostic is very easy. It is not, the manometry is not always necessary. Of course, yes, but for you, if you got some experience with a dilated esophagus that it is a primary achalasia. Another one, very interesting. I love this disease because sometimes you put a name on old symptoms that the patient presents. There is more and more patient with this disease. I don't know what is your feeling, your opinion with the time, but in our country, in France, we have a lot of patients like this. It is not always easy to diagnose this, especially in white lumen endoscopy. But you will see that when you put BLI or NBI, it could be very interesting. This patient was a young man. He presents some dysphagia with food blockage infection at twice moment of his life. And he benefited from 2 previous gastroscopy without any diagnosis. Why? Because you have to perform biopsy of the esophagus. And it is the reason why we told you to perform biopsy systematically in the esophagus, even when there is no lesion, when you have in face of a dysphagia. And you see very well this ring aspect with the furrows. And this is very specific from this disease. Sometimes there is edema, there is exudate. And most of the time it is associated with atopia, asthma. And we call sometimes this disease the asthma of the esophagus. And it is eosinophilic esophagitis. Again, very interesting diagnosis. It could be the same lesion when we compare with the granular cell tumor from the previous case, but it is not this diagnosis. We are inside a Barrett esophagus because you can see that the mucosa is a glandular mucosa. There is a very clear in BLI modification of the pit pattern and the vascular pattern with a demarcation in this patient with a whole Barrett esophagus and some ulceration, and we perform a dissection. You can see the result, the final result of the dissection. I come back to the lesion, maybe, but it is very interesting and I think easy diagnostic. You can see that there is 2 components. First is slightly in some area depressed or surelevated, and there is a nodular lesion, and in Barrett esophagus, when you got a nodular lesion, there is only one diagnostic to put, and this is the adenocarcinoma, of course. Another esophagus on the lower part of for this patient seems to be a modification of the cardia, book aspect, subepithelial lesion maybe, just above the Z line, with some esophagitis, because it was peptic esophagitis, but it is not a diagnostic for this patient. A large lesion, and we decide to perform US, and you can see very easily this very hypo or anechoic lesion, which is described depending from the muscular layer, more than 2 centimeters. We do the sonoview. You can see that there is no enhancement of the lesion, which is a good sign in this situation, because you know that you can differentiate the different type of subepithelial lesion in the esophagus like this. And a biopsy was performed, but the diagnostic in the esophagus is easy if you... It is a leiomia of the esophagus, of course. It is a benign lesion. Sometimes there is some symptoms. Most of the time you don't have to treat the patient, but in the esophagus like this, subepithelial lesions are most of the time leiomia. So last video, it is maybe the case of the year in my unit. This patient, this young patient, was referred in the unit for an abscess in the esophageal wall, and we observed some pus from an fistulous orifice. And I decided to drain the abscess with an incision. And you can see that we aspirate all the pus inside the abscess, and it was like a cavity. First, during the first session, I tried to close the defect with TTS clip and a pigtail, but of course, after 2 weeks, the cavity was well organized, the clip fell, the pigtail was inside the cavity, so I decided to retrieve all the material, and due to this cavity, I decided to perform a complete section of the esophagus between the cavity and the lumen of the esophagus. So I use a tic-tic knife, and I do like a poem, but for the mucosal side of the esophagus. Just to put on flat the abscess, or the cavity, the previous cavity of the abscess. You can see that there is no muscle finally between this cavity and the lumen of the esophagus, so it was very easy to perform. And I go to the bottom of the cavity like this, just to open the wall. Some coagulation at the end. And when we do like this, 4 months later, can see the esophagus. It is not a normal esophagus, but the problem that we focus on the abscess, and you can see that there is a scare, but here it is a scare of the cavity, and you can see that there is a reepithelialization of this cavity, but when I go inside the esophagus, we found some edema, we found some exudate, some ring aspect, and some furrows. So finally, in this young man, it was clearly an esophagitis, you can see, with an RFS score of 5. And if you want to have another argument for this disease, try to do a biopsy, and you can see this sign. It is a pull sign, which was described in gastrointestinal endoscopy by a team, and it is very specific from the diagnostic of eosinophilic esophagitis. So thank you.